Well, hello, everybody. Good afternoon or good morning, depending on where you are. My name is Garrett Schmidt, and I am the managing editor for BBC Exhibit Hall. And I'd like to welcome all of you to today's live webinar hosted by ATTAC Consulting. And really excited about today's session, and it is titled "The Future of Medicaid Reimbursement. So what do proposed regulations mean for provider and health plan reimbursement?" And there's a lot of great material to cover. I got a little sneak preview the other day when we were going through it, and so I think you'll really enjoy the presentation today. A few items of note before we get started, and then I'll turn it over to our speakers. Everyone is joined today in listen-only mode. This is traditional webinar format, so you don't need to worry about muting yourself or turning off your camera. Don't worry, we can't see you. But we do want to hear from you, and we are going to have some time for some Q&A toward the end. So if you have a question at any point during the presentation, go ahead and ask it using your control module. You actually have a little place for questions there, which is different than the chat. So go ahead and drop your question there, and we're going to get to as many as we can during the allotted time today. If for some reason we don't get to yours, don't worry. Someone will reach out to you via email afterwards and answer your question for you. So, but yeah, please ask your question. And then finally, today's session is being recorded. So what's going to happen is when we're done, I'm going to send over, or someone will send you an email, and you'll have a link to the recording and where you can download the slides and interact with the team and get some other information there. So, and hopefully that'll also be something you could share with colleagues or rewatch again. Hope that you do. Without further ado, I would like to turn it over to our moderator today, Mr. John Gottwald, and he is the SVP of Sales and Client Services with ATTAC, and he will introduce our speakers. So welcome, John.
All right, thanks, Garrett. Good afternoon or good morning, everyone, depending on what time zone you are in, like Garrett mentioned. All right, a little bit about ATTAC. A lot of you know us. A lot of you are clients on the call, but we are celebrating our 20th year this year. And I think we actually already passed the actual date, but we're 20 years old this year. And among other things, we specialize in Medicaid bids, provider access and availability surveys, as well as provider network development. And speaking of, our two speakers today are Jocelyn Bayless and David Giles. A little bit about Jocelyn. She's ATTAC's division lead for our National Provider Network Development and Management team. Jocelyn has about 30 years of experience in the industry. She manages large-scale provider network engagements, as well as focuses on network development and management strategies. And also, she's in charge of our provider network operations practice. Prior to joining ATTAC, Jocelyn held senior roles at Wellgar Health Plans, which we worked together at way back in the day, Florida True Health, and she was Chief Operating Officer for a mid-Florida ACO. David Giles is also around 30 years of experience, so together you're getting about 60 years experience today from our speakers. And David has worked with health plans, physician groups, and hospitals in his career. His focus has been on market and product development, healthcare reimbursement and financing, and also did development and management of large-scale provider networks. David's worked across all lines of business, including dual eligible plans and contracted providers. And he's had a very strong focus on what he does mostly for us is implementation of value-based and risk-based reimbursement models, including setting up the analytics for those. And prior to joining ATTAC, David worked at Humana, Blue Cross Blue Shield, and Carolina Medical Care. So without further ado, I will turn it over to Jocelyn to talk about our agenda for this afternoon. Jocelyn?
Hello, everyone. Thank you so much for joining us today. We have a lot of content to share with you. We're going to go over the key highlights, and also, as Garrett shared, we'll be providing this presentation so you have all the details. But at a high level, we're going to talk about what does the future Medicaid reimbursement look like. Obviously, that's the key of our presentation, but we have a lot of good information for you. And then also talk about some of the impacts of those proposed regulations. Hopefully you all responded to the comment periods on these. There's some pretty significant impacts. And then what will the impact be for proposed reimbursement requirements and the current VBP mandates that they have on the Medicaid bids? So with that said, I'm going to get us kicked off and running with the the first poll question. John, if you want to go ahead and take it away.
Yeah, absolutely. Thanks, Jocelyn. All right, so we're going to have 3 of these just to make sure you guys are paying attention. And the first polling question, how many of you, and fill in the blank, and please select all that apply. So how many of you operate a managed Medicaid plan, managed Medicaid behavioral health plan, sponsor ACO, or have heard of HCP LAN? And your screen is going to change. Again, please select all that apply. It looks like we got about half the people have voted.
And as an editorial note, your answers are confidential and anonymous, so don't worry about that.
Yeah, you won't be getting any questions on your social media feed after you select. Okay. Leave it open for about 10 more seconds. Looks like people are still trickling in and voting. Okay, I'm going to close the poll. And you should see the results. Looks like over half of you have heard of HCP LAN or LAN, so that's good. And it looks like we have a mix of the audience there, which is good. Okay, so not to distract you, we are going to go off camera. And I'm going to turn it back over to Jocelyn.
There you go.
I'm sorry.
And actually, I'll interject as David presents the next set of slides.
Yeah, sorry about that.
That's okay.
I guess, first of all, to set the background, if you're here for regulatory compliance or some other reason other than to try to see what the future looks like and to make some educated guesses on that, it's probably the wrong webinar. Because what I would really like to do is to step back and take a look at what would happen 5 years from now, not just what's in the current regs, but what do you read into those regs, the proposed regs, that would help you design reimbursement for the next several years. We know that on Medicaid, much of this will be customized by state, and I see by the number of people attending that you come from all kinds of backgrounds. And I would say some of your organizations may even be a part of HCPC land. So we got good response on that. And that we'd be interested towards the end of this for you, not just your questions, but some of your insights on those things. As a bit of background before we do the reimbursement, you can't just look at the proposed regulations in isolation. You have to at least acknowledge and keep aware of what's going on with the general trends. If I could have the next slide. Won't bore you with all the numbers. There you go. Most of you are aware of this, of what's going on and what happened since COVID and what happened since Medicaid expansion. But it really is almost shocking to realize we're pushing $1 trillion on Medicaid, and that somebody's going to, quote, notice that for good and do something about it, especially as Medicaid has become federalized. With the Medicaid expansion, more money comes from CMS. So this is what you could assume is going to happen long term. The Medicaid spend and the increase, the guess here is, are those lines going to continue going on their trajectory, or whether they're going to level out? Is that some of that caused by COVID? We know we have recertification coming up. What's that going to do to this? Is it going to push them to the ACA plan where CMS seems to trying to attract a bunch of them? And then there are a number of states, 10 of them, including North Carolina, that have yet to expand Medicaid. In North Carolina, ours is tied up in a casino bill, so we have healthy casino workers on Medicaid apparently. But there are a number of states that are looking still to expand Medicaid, and that will affect these trends even more. Next slide. I mean, when we looked at Medicaid decades ago, we always said, oh, women and babies. So you have to have plenty of OB-GYN, plenty of pediatricians, and that was your big expense. And by the way, if you look at their hospital utilization and the rest of that, forget the older folks who are in duals or in nursing homes. But if you look at the base Medicaid population, women and babies. Now look at what is happening with the expansion. Most of the adult portion of Medicaid is growing faster than the child enrollment. And in addition, the last figures I saw, 46% of the enrollment in Medicaid is now male, of the adult male. So what you have is a changing in service mix, and that changes your provider network. It changes how you do reimbursement, and it changes what you have to think of in terms of your total spend. Next slide. We were actually working with a client on a Medicaid bid several years ago, as it says, when the letter dropped to all the state heads of Medicaid from CMS on what needs to happen with value-based payment. And if you don't have this letter, you're not familiar with it, we'll be glad to send it to you. Just email us. But what CMS was saying is we need to do something with value-based care, and that dictate got pushed down into the bids. The bids that we were working on required very specific types of value-based payments over various numbers of years. And this was enforced through CMS or encouraged from CMS to the state level. And largely the VBC they were talking about, as you read the letter, has to do with HCP land, meaning Healthcare Payment Learning and Action Network. Next slide. If you have the HCPC land stuff, you've probably already seen what they have proposed overall. And what they have focused on is not just Medicaid, but also Medicare and commercial. And CMS is a part of HCPC land, along with, like I thought, some of your organizations might also be part of it. So it's CMS kind of pushing it, but there are major provider systems on there, health plans, some other organizations, and they've come up with a set of guidelines of what they think value-based payments or value-based care is. And they have basically, through the bids and through the contracts and just general cajoling, you tried to encourage states to use the land model as a guide to value-based care. And beyond that, what the land model does is encourages you to use the CMS, APMs, and ACO initiatives as models for Medicaid. And some of that gets put into Medicaid bids and contracts, and the ones that we have seen is you get additional points based on your, in effect, land score. Okay, next slide. If you haven't already, it looks like most of you are familiar with it. What I'd point out about what we've seen on the Medicaid bids and what we expect to see in the future is only Category 4 counts, maybe 3B. They want downside risk, they want population health, and they want it tied to quality. What has always interested me on this is if you look down at the bottom, you see 3N, that means no, and 4N means doesn't count. And that's just pure cap. Well, those of you from California, I assume we have some, if you look at the contracts in California, not just for Medi-Cal, but other things, you'll see a full capitation for physician services. And that capitation is not typically directly impacted by quality incentives or whatever. The service fund, where they share in hospital savings and the total cost of care, that could be tied to quality. But that full capitation, which I would certainly think counts as population health, is not tied to quality. Those IPAs turn around, take that capitation, and they pay that out to all of their primary care and specialty groups and whatever else they're at risk for. And so to have to reserve or to hold back money that they've historically for decades paid out directly based on some quality take back is a very difficult thing to do. So I think not counting full cap is something that HCPC LAN has mandated there, and it doesn't, in our experience, the bids we worked on, 3N and 4N don't count. But that's population health and it is risk management, and you can tie contractual obligations under those full cap contracts to performance, but not as a specific penalty bonus. Okay, next slide. As you see in a bit, these are the results by line of business. And if you look at Medicaid, projecting that by 2024, they would like the goal to be 25%. They're, depending on how you count the category 3B, they're at 16%. So even if they throw in 3B, they're behind schedule. And on the Medicaid overall, I think we'll look at that in a minute, is about 4% is what CMS counts overall total Medicaid spend. Okay, next slide. This is sort of our take on when we work with Medicaid health plans and providers, because we've done both sides, of what of all those mishmash of MIPS and APM and ACO and all that stuff that CMS has put together for Medicare and to some extent Medicare Advantage, which ones we think work best and easiest for Medicaid. And remember here that we talk about these models, you're taking into account that there's going to be more adults, there are going to be more males, more hearts, more kidneys, more that sort of stuff. So if you look at the primary care first model, in general terms, what that amounts to is determine a monthly global payment, and approximately half of that is paid out in capitation, and half of that is fee for service. And of all of these APM models, on the primary care end, that one has the broadest base across the country. You can get the list of CMS, from CMS, of the primary care physicians and practices that are involved in primary care first. So if you know they're already doing this for Medicare, and you have something similar, it won't be exact because you do not want to administer that the primary care first model, where you give them some cap up front, and then you give them some fee for service, and that is tied to the total cost of care, where they share on that based on certain incentives and certain quality indicators and a number of things that we like to see in there, such as you want incentives in there for bringing people who are totally either unassigned. If it's a health plan enrollment, they may not have a PCP. If you get them into care, you should have a certain percentage of unassigned people that you work to bring into your practice, because that's important for a whole bunch of reasons of the other quality indicators. If you're not seeing them, you're not counting them. The other thing that we like to see is in those quality indicators, this is where you can tie those of the total cost of care and those savings to a number of flexible quality and performance indicators based on what your state contract is looking for. And so that the primary care practice gets cash flow up front. If you have a whole bunch of people come in, they still get paid something fee for service. And usually the 50% of fee for service is the normal plan fee schedule. So they get half up front, which is good for cash flow. That's what they wanted during COVID. Remember during COVID when all these practices were starving because nobody was coming in? And a lot of commercial plans gave them money up front, just like primary care first. So of the primary care models that are easiest to implement, this is one. The other thing we know from our work that this can be configured fairly simply in most health plan systems. And also from a standpoint of the practice or the primary care practice, since they're submitting a claim for something as opposed to just for informational purposes, you get a little better data because you're actually paying them 50% fee for service. And that can vary. You'll have practices that may want to take 70% cap and some that may only want to take 30% cap. but maintaining some percent cap and some percent fee for service. I think it's important for at least to have some fee for service in there to get the data and to protect that practice against a large swing in utilization that you don't want to be modifying the capitation every week or month. The other thing with the primary care model, as CMS envisions it as a way to keep primary care practices independent. But if you look at primary care first, one of the things it's done is feed the venture capital primary care groups, where this is very attractive to them to get this kind of reimbursement and have access to that total cost of care savings. And so the venture capital PCP groups, and we've worked with a number of them, they don't even want fee for service to be their only means of reimbursement. What they're doing is using that service fund to offset additional appointments and all the rest of that on the primary care groups. So this is a model where you look at reimbursement. Some of these venture capital folks will come into the market and make change more rapidly than what your primary care or hospital-based groups are willing to do. In fact, when we were doing a bid, and a hospital executive asked me to try to find out, which I couldn't tell him, what these venture capital companies are paying their primary care physicians, because they were stealing his docs. So I think from a provider standpoint, you need to be aware of that. But it's a model that works well for primary care. Now, the episodes of care, historically, this was all OB related. Episodes of care and the bundled payments. But Medicare hasn't, the episodes of care stuff from the CMS APM model, they've really all gone to bundle payments, like the ortho groups. But on the bundled care that we've looked at for Medicaid, the obvious one is OB. You would think you could do that. Okay, we'll do what we've always done. We'll give you a bundled payment for normal vaginal delivery and C-section. And then we'll give you a bundled payment for prenatal care. Then we'll give you a bundled payment for any follow-up care and a global on what the total cost of care was. Well, if you're looking at Medicaid, and we talked to the OB group, the first thing is we can't be responsible for C-section because these people aren't coming in 2 months prior to delivery. So then you say, okay, we need to get the primary care physicians involved. So you go to primary care and say, we need your assistance in identifying pregnant patients early and getting them referred to an OB. And they say, we can't identify them because they're not coming into us either. And then you say, well, what's the next step? Well, we'll go to the community health center because they have all these people for outreach, and we'll involve them and help. They'll use their outreach people to get them in either their PCPs or our PCPs. Then we'll get them to the OBs, and then we'll all share in this. Well, that gets complicated. If you're putting this in a bid, you don't save this for the last minute because there's a lot of hands that are required to get this one to work. Bundled payments. If you pull the bundled payments for care improvement on the CMS site from Medicare, and you look at who's doing this, the heart guys and the rest of them have pretty much been washed out because they couldn't figure out how to split the savings and how to make a buck, and CMS to some extent couldn't figure out how to count who was a patient and what expenses should go against it. But the ortho groups, again, a high number of them, either large, well-established multi-site ortho groups or a lot of venture capital money in orthopedics, and they love it. They took the joints, they took hips and knees, and on Medicare, they also knew the biggest play was not using a hospital. So many of these groups already own an ASC. So there was like instant savings to avoid the hospital. And that impacts, by the way, what the hospitals are going to do on this. But they package that with pre and post. And to some extent, I mean, the hospitals will argue, well, they're not getting the sickest patients, but there's risk adjustment involved for Medicare. And if you were to do this for Medicaid, you would want to know that the adult population and the older adult population, with or without the duals, is going to be sufficient enough to implement something like this. So this is one, your guess is if it's a state where you're pulling in, your expansion state, you're pulling in a lot of adults, those adults aren't waiting to hit the Medicare duals program to get their hips replaced, then this might make sense. The per diems and DRGs for post-acute, we had an interesting situation. It was actually Hawaii, where they were implementing DRGs. And this was something we'll talk about later. This is almost a state-directed payment that all the health plans and any direct payments from the state, everybody was going to use DRGs for every hospital, every adults, kids, whatever. And there was some advantages seen by the hospitals who we thought would be most would object the most to the DRGs, because they had been getting low per diems and they knew what they were getting, and they would get the per diem for every day the patient was in there. And the biggest thing that we found is what you would probably find in most states is under a DRG, the hospital's at risk for the service. But if they can't discharge that patient because the patient doesn't have a suitable home, the patient has nobody to look after them, you can't do hospital at home because it's not a suitable place, these waiting days increase the cost of the hospital for them to get them out of there. So who do you have to partner with? Well, there's a number of post-acute forms. One of the things that you're seeing in both MA and Medicaid is the hospital at home people, and a lot of the systems are also doing this. It's not just the venture capital folks, but the hospital at home people are coming in and saying, we'll do this. And then the question becomes, where are you going to take them? And they're not all homeless, but some of them don't have home situations that are conducive to hospital at home. And they said, okay, we'll rent motel rooms. We'll take motel rooms. So we'll rent a block of space. So it puts into place a whole number of issues here that isn't just hospital at home. And when you do DRGs or do almost any VBP, this is an example of sort of unanticipated consequence. And you can say you should anticipate that, and a lot of them did. So it becomes trying to put something together that builds the relationship between the hospital and the post-acute care. Many hospitals could do this on their own, and they expect to get paid for it. And they also save on the DRGs, but they do expect to get paid for the post-acute. They're not going to take that out of savings. But there are some packages that can be put together on that with states that have or are going to DRGs that could be attractive to both the payers, the providers, and also better patient care. The social determinants of health, there's a lot of talk about that. And this is a case, if you look at the DRGs, where it's definitely impacted by that. And I think if you structure this right, you get credit for that. That it's not just get them out. There's the SDOH component of that, where you do discharge assessments and needs assessments and bring in the resources necessary to make sure that patient doesn't come back on Monday, that you also get credit for the SDOH. The CMS Ahead model, this is the basic model of this, where it's total cost of care, global budgets, and all the multi-payer. This has been around for years with Medicare. However, this just came out this year, where they decided to name it the Ahead model and use it for Medicaid. And the multi-payer model under Medicare is to try to get not just the Medicare Advantage payers involved, but Medicaid and commercial. What they have done is taken this model and, excuse me, and in Pennsylvania, the PARM initiative, where they've taken the rural hospitals, interesting, some of those owned by large systems, and they've tried to get, and have done it, it's been implemented, the total cost of care and total budget, and the plans pay in advance, so a rural hospital can plan what their revenue is going to be, make a transition to value-based payments and help social determinants of care. And they can involve the PCP and community and rural health centers. Pennsylvania has a large presence of both of those. And I think when you design these things, I would be interested, if any of you were involved in that, to see how that turns out, or how it's turning out. That the issue there with rural hospitals and total budgets, you have to be conscious that there's going to be a leakage, that they're going to be paid up front for certain services, but they may get transferred to tertiary care, big cities, whatever. And that gets complicated when you're doing this on your nickel instead of Medicaid's or the state's nickel. Okay, next slide.
All right, actually, the next slide's a polling question. We're going to give you a little bit of a break. The This is a Green Bay Packer reference. If that was in Pennsylvania, it would be called farm. Kind of like how Favre pronounced his last name. Okay, thanks, David. I'll give you a little bit of a break. We'll transition to our next polling question. Should state Medicaid managed care bids require a single vendor for medical, behavioral health, and community care service? This is a yes or no question. So you should see the polling box on your screen. And again, should state Medicaid managed care bids require a single vendor for medical, behavioral health, and community care services? And these answers will be strictly confidential and not be held against you in any way, shape, or form that we know of. Okay, we got about half people voted, so we'll keep it open for a little bit longer. Okay, about 10 more seconds and I will close the poll. And look at that, an even 60-40. So looks like 60 said no and 40 said yes. Okay, interesting results. And back over to our speakers. Let's see, there we go.
Yeah, that's interesting on the results. I guess it depends whether you already own behavioral health or community care services or what the state does. So we can talk about that some more later. Okay.
Yeah,
when we look at the regulations, I'm not going to go through them in every detail, but I would like to have all of us thinking about reading between the lines. I like the proposed regulations better than the final regulations. They give you a better sense of what they're really thinking down there at CMS, and also who's going to respond and whose ox is going to be gored. So you get all these responses, like we'll see with the academic medical centers, and if the response is really bad, they may hold off for 2 or 3 years. And if I look back at some of the proposed regulations for both Medicare and Medicaid, my favorite ones are the MA ones, where the proposed regs, they were going to do a national directory years and years ago. We're going to have a national directory because you health plans can't keep your provider directories. And that's been talked about, not just for Medicare, but also Medicaid. Only now, with some venture capital backing, is anybody really attempting to do that properly. And then again, they were going to have capacity standards that you were going to have to survey docs and figure out how many spots they had for patients. And the silly thing there is you didn't know whether they were going to use them for Humana or Centene or Blue Cross or somebody else. So they said, okay, we came back years later with access standards where there's waiting times and all the rest of that. And that's what I see in these regulations now, access, because it doesn't do any good to have a Medicaid health plan if the patients aren't getting seen. And a lot of what was in the proposed regs, and I'm only dealing with the reimbursement stuff, is how to basically make sure we have access, how to penalize plans, put them on the naughty list, or allow VBP to encourage it. We'll talk about just briefly the access standards for behavioral health, primary care, and OBGYN, knowing that many states have more detailed ones. Some don't even have that, so it'll vary by state. The other thing is they've been talking for years about the state-directed payments and the supplemental payments. You all are probably familiar with, we tax the hospitals and then we take all this money and we get the feds to match it and then we give it back to selected providers. What used to happen was a lot of that went to academic medical centers, safety net hospitals, and hospitals that would deliver babies. But I think when you start putting more adults in there, you're going to need to do more than just bribe hospitals to deliver babies. And so the reimbursement, supplemental payments will probably need to change. And if you're on either side of that, a health plan or an academic medical center, you probably ought to keep an eye on that. The reimbursement levels, as you probably know, that is typically set by state. The feds are saying if you're spending our money, we may want some say in that, and that's what I see as one of the trends in the proposed regulations. Next slide. You can go through these. I think just some of the highlights. It's one thing to pay for access, but if the access doesn't exist in primary care, you can bribe those people all you want. They just don't have capacity to see these people, or they don't want to devote a percentage of that to Medicaid members. But I think what you see on the Medicare end with the venture capital groups coming in and setting up PCP groups, that they can see 10 patients a day and stay alive because they're working off of that service fund. That they get back to something like Primary Care Plus or a version thereof with health plans or directly with Medicaid, depending on the state. And it makes sense to provide access at a premium price. In other words, they're willing to take a loss on the access, getting patients in, because they're going to manage them against the service fund. And all of those venture capital PCP groups that work in Medicare and often will only take Medicare Advantage members, with the change in demographics and the VBP emphasis on Medicaid, I'm not going to be surprised if they start calling us to see what they could do for Medicaid. So they have the same incentive. And if you're a primary care group or you're a hospital, that moving to that first and making sure there's access and working against that service fund from a health plan that is now incentivized to do that for you would be a good idea.
And David, I think it's important too that plans are looking at their access survey results in a meaningful way to actually identify those geographies and specialties that have the most opportunity to improve access to care. Not just looking at, are they compliant, are they non-compliant? It's really about where are those gaps and shortages happening so you can come up with a good plan.
Yeah, and I also think you're going to do access for more than OB and peds. You look at who's coming in, you're going to need to survey cardiology and the rest of that. And that will eventually, that already happens in some states. We know of that. So there are states where that happens. So if you're
Absolutely.
in a state, and if you're a state that only requires survey the OBs and the peds, you should be prepared for that. Next slide. All of the, and Jocelyn, feel free to jump in. The access requirements will vary by state. Some states are getting very punitive about that. What I would say again is on getting capacity. What we're seeing in the commercial market is people don't want to wait for appointments, and they're going to urgent care centers and they're doing the rest of that. In the last 5 years, the waiting times have actually decreased overall to see a primary care physician because people are peeling off and going to CVS and Ready Med and all the urgent care centers.
And I'm actually hoping on the proposed regulation that they don't go to just secret shopper. I find in the surveys and the clients that we've worked with across the United States, you get a lot more meaningful feedback when you can do more of a hybrid approach. And when you identify as a plan, you can actually get to more of a root cause when there are barriers to care. So I'm going to definitely be keeping a pulse on this one as well as some of the others to see where it's, where it actually lands. But I'm hoping that we can have that flexibility to where it's not just secret shopper and you get limited information.
Yeah. And on the access, the one thing that I think works fairly well to encourage access is you can have a fee schedule with when you get a new patient in there, and that's primarily what the focus of the access is, get them into the system. Having a high fee for that first visit, beyond what's allowed by cheating the E&M codes, that you assume a first visit is going to be a significant visit. It's going to take extra work on the staff's part to get them in there, get them set up, that compensating primary care practice, especially for that first visit off of the fee schedule, to the extent you can do that under the cost accounting rules of your state, is a good investment in reimbursement. Next. Try to save some time here. What my take on the proposed regulations getting close to Medicare? I think in some instances, by increasing the Medicaid fees closer to Medicare, and as you can read, that's part of what's going on with the proposed regs. The states are going to have to report that, and they're going to shame states that are just paying 20% of Medicaid to keep their costs low, and no providers will take it. But if you increase the Medicare fees or the Medicaid fees closer to Medicare, we've always asked, is that going to discourage people from taking capitation and VBP? Because a lot of specialties and groups would probably rather take their chances with fee for service. The other side of that is, if the fees for Medicaid get closer to Medicare, then the base, the target level, will increase, and it makes it worthwhile to take VBP. And that's where I see the venture capital primary care groups keeping an eye on this. So if the fees increase, we can now make a buck of doing the primary care first model in Medicaid. Or you could make a buck as a primary care or hospital system in Medicaid, because as that comes up, gets closer to Medicare, well, you're getting your revenues. You obviously love what you get from Medicare, with obviously a bigger service fund because of the older patients, but you have a similar model and some revenue targets that fit your business model. This was part of the reason for the question on who owns what. We do see, even if they're separately let contracts for Medicaid between medical, behavioral health, and community care, you're probably already aware of the number of Medicaid plans that are buying both post-acute, that are buying or already own behavioral health services, and particularly lately buying home and community-based services and that piece of it. So even if it's not a combined bid, putting those together potentially leads to some savings. And could I say better revenue for the health plan? They're taking it from 3 pools, even if it's 3 contracts. Or even if they don't get the medical piece, they have the option of getting a piece of the Medicaid business, staying engaged in the state. So it's a good way to share the risk. Okay, next slide. So how do you think providers will respond to VBP? I mean, having academic medical centers publish their average commercial rate and to assure CMS that they're not charging Medicaid more for selected services than they're charging the commercial plans could be an interesting decision. I expect a lot of comments from academic medical centers on this. This may be a stalking horse. A lot of what I think CMS sees is Medicaid's being used to prop up the state's academic medical center and care that they don't want to fund themselves. So they're trying to say, okay, you're charging us these rates, and that comes back on the cost center, and then we approve payment for that. I don't know if this gets implemented this year, but it's interesting to see it. Determining the true commercial rate will take 10 years. I just put that in there as a guess, because I think as the hospitals have done now, how long does it taken them to implement price transparency? Well, still working on it. Some are ignoring it. And what I think you're looking at is what health plans get to use that money for, whether they're doing it for rate support, doing it for fee schedule support, or what the states decide. Next slide. Go ahead. State-directed payments. This is addressed a number of ways in the regulations, but state-directed payments overall are a small percentage of the total Medicaid spend, at 1.5%, but they tend to package them and go to certain types of organizations. For instance, when I look at what they're currently doing with supplemental payments that also come down to what the state is directing the health plans to do. Right now, only 4% of those supplemental payments are for VBP. 72% go for across the board increases, and 19% go to minimum fee schedules, as we have in North Carolina, where it's a percentage of Medicare based on certain specialties. So 4% of that is going to VBP. They would like to shift probably a lot more than that. Next slide. We actually think that there will be more integration of state bids on medical, behavioral, and community, particularly because as we talked to with the DRGs, we had to bring in the relationship with the home and community-based services to get the DRGs working properly and acceptable to the hospitals. So if you're already there as a health plan, that could be an advantage. The politics of that, though, particularly, I would say on the community care and HCBS organizations, they're probably going to fight that. And I think some of your answers reflect that. The last point about the VBP models tied to the APMs and land, I think the ones that are applied to Medicaid now will change drastically as the demographics change, and quite frankly, if more money comes into Medicaid through Medicaid expansion or just general cost increases, that we will see. One of the big trends, I think you're going to see the same type of stuff we see in Medicare Advantage with the venture capital ortho groups, the venture capital PCP groups, and it brings into play the chronic kidney disease companies that will manage all of that stuff, not necessarily chronic kidney disease, but those single specialty, well-funded venture capital groups will come in and want to work with you or to take that directly from Medicaid, excuse me. Next slide. Quick thing on audit implications. As always, the more stuff that gets shifted to population health, capitation, value-based care, I think if you are a related entity, a health system that owns a health plan that owns a hospital or whatever, or a physician group, and that your reimbursement, whether it's VBP or any of the models, or if you're paying excessive fees just for reporting, which isn't considered a quality of care or value-based payment, that when you do an audit, those things get scrutinized. And when you do value-based payments, there could be refunds, changes in premium, changes in service, all of those refunds and overspending. Providers and plans need to consider that, reserve for it, and prepare to pay CMS back if appropriate. We're seeing this in Medicare Advantage with you do the risk assessment audits, and if you've already paid out based on one number to some ACO, you need to figure out who's going to pay CMS if they come knocking. Last thing, you can use HCP land as a guideline of what qualifies for value-based care, but it's not a safe harbor if the other numbers don't make sense in the market and inconsistent with the other regulations. So it's a good place to start when you're structuring these arrangements. You can use the guidelines, particularly category 4, but it's not a total safe harbor. We've been involved in some of these, and it means good sense with HCPC. Okay.
All right, thanks so much, David and Jocelyn. This brings us to our final polling question. And that is, what do you think will be the biggest impact on reimbursement if proposed regulations are adopted? You should see your screen change. All right, looks like about a third of you have voted, so we'll keep it going. Very interesting results are coming in. Okay, we're a few more seconds. We'll keep it open. Okay, I see some stragglers coming in, so a few more seconds. We'll keep it open. All right, I'm closing the poll, and you'll be able to see the results. Now, the interesting thing is that unbeknownst to David and Jocelyn, I put number 4 in there for other, and exactly 0 people selected other. So
That is interesting.
very.
These people aren't new to this, John.
Yeah, clearly that was a test, right?
Yeah, that was a test.
All righty. Okay, now I think it's time for some Q&A. And looks like we've got some in the control box. So I will read the first question, and then David or Jocelyn, please feel free to chime in. And the first one that came across is, will Medicaid ACOs become as widespread as Medicare ACOs? And how will the reimbursement work under a state/federal umbrella?
I guess the first issue there is whether it is an official Medicaid ACO like we have in Vermont. If you're familiar with that one, where it gets paid by the states. These tend to focus around large delivery systems or academic medical centers, and it's handled by the state, or Medicaid ACOs that are subcontractors to a health plan. And if it's from the health plan, they'll have a lot of the things we talked about today. In order to get that payment to the cost report, it's going to have some elements of VBP in it and tied to quality. On the state end, I suspect that those direct ACOs, like, look, again, I'm familiar a little bit with Vermont. There are others. That's a direct payment from the state. And what they've said is, give us the money up front, we'll take the risk, and we'll be done with it, within reason. So I think it depends on which one you're talking about. The state ACOs, I don't think they're going to be as prevalent as Medicare ACOs because the states are all going different directions. But the ones that come from health plans, they already exist widely.
Yeah, I agree.
All right, thank you. Okay, the next question. Any thoughts on how dental services are reimbursed?
I want to say right now, minimally. It's tough to get dentists for Medicaid, except in many markets, we have venture capital firms funding dental groups that concentrate exclusively on Medicaid or largely on Medicaid and duals. So what you're seeing is people coming into the business that see somehow, and some of those are fully capitated arrangements for dental care. They're taking the money up front, organizing the practice, and getting away from the low fee for service that Medicaid covers. And Medicaid doesn't necessarily cover everything and doesn't cover it at approximately 20 or 30% of charges. So I think the way you deal with dental reimbursement is the way the venture capital people are. And hey, I'm not paid by venture capital people. I just watch if they're willing to put their money in it, there's something there, and we follow that, follow the money. So I think on a capitated basis, it makes more sense than trying to do it on fee for service. There are a number of fee for service dental providers that are now in jail. So I think if you do it legitimate and just like DME, but the answer there seems to be broader than just taking fee for service. And there's not a whole lot of VBP other than capitation with some quality indicators that goes into dental care. They're not giving you credit for impacting heart disease or whatever.
Yeah, absolutely. Okay, next question that came in. How do you see non-physician qualified health providers, audiologists, speech language pathologists, etc., operating within value-based care and Medicaid?
Well, you got a couple of populations here. You got the speech pathologists and audiologists. A lot of times that's traditional Medicaid with the children and to some extent CHIP. And if there are capitated arrangements with large groups and hospital systems, they get thrown in there as part of the capitation. If you look at California, a lot of that is part of the capitation, and that's part of the delivery system. Standalone, I don't personally know of many standalone VBP reimbursement just specifically for those types of providers. You see some of that on the testing and on the autism, where they will take not necessarily capitation, but episode of care payments, and that's probably appropriate. If I were one of those providers and I didn't like fee for service, I would take episode of care, because there's money when you get a patient. They come in a lot, but not a lot of patients are necessarily coming in.
Yep, absolutely.
Yeah, I would agree.
Okay, and the last question that came in, how do you see the changes to Medicaid reimbursement impacting community and rural health centers?
Well, John, first of all, the Pennsylvania Dutch pronunciation is Parma, not Pharma.
Ah.
So, however, I think when we worked with community health centers, both on the payer and the provider side, the first thing that comes into play is we're really nervous about our encounter rate, because as many of you know, they get an encounter rate, costs go into that, and they really don't want to move away from that. So when you're talking about value-based care, you have to offer them something that both under the regulations and practical reasons doesn't totally destroy the way they act, the way they get reimbursed now. And what we found is there are incentives to do that you can put in place that they are appropriate for rural and community health centers. They are particularly wonderful for going out and tracking down patients. Most primary care practices don't have a couple people on staff to go, quote, do community relations and deal with the community and get them into care. And that's why we tied them to the primary care group on the OB thing. They can be wonderful for that and can share in those incentives. I think the Pharma Parma program, where you have all those rural hospitals, many hospitals actually sponsor or own the local rural health center. And I think they're going to be included in the rates for that, the incentives for that, and as part of the transformation that the AHEAD program is looking to do. That's the fact of life in the rural areas, not just Pennsylvania.
Yeah, absolutely. All right, well, thanks, David and Jocelyn, for the questions as well as the presentation. And I'm going to turn it back over to Garrett.
Hey, everybody. Well, hey, thank you all so much. This was a wonderful presentation. There was so much here, and you may have felt the same way. It's like, wow, there's a lot to draw from this. Luckily, you will have an opportunity to watch it again and to download the slides. So I'll send you guys a link afterwards. But real quick, as we wrap up, wanted to encourage you all to head over to our virtual exhibit booth for ATTAC Consulting Group, and this is at vbcexhibithall.com. So if you head over there, there's a link here on the slides that'll take you directly there, but go check it out. There's a lot of great materials to be able to see, do a little homework, dive into what they're doing, learn a little bit more about them, educate yourself, and then of course you can reach out to them through there. And then finally, if you would like to reach out to our speakers today, feel free to do so. Their information is here on the screen as well. And again, this will be in the slides also for you. Or feel free to reach out to me. I'm happy to facilitate an introduction for you and put you in touch. But I wanted to thank again our speakers, Jocelyn, David, John. Thank you so much for your hard work in putting this together. And I think we're going to be having another webinar coming up in a few weeks. So stay tuned. We'll be sending out some information about that soon. So keep your eyes open. But thank you again for joining us. Hope this was a wonderful presentation for you. Have a great rest of your days. Bye-bye.